Buckle up.
No? Is that okay. All right, let's do this.
Mr. Chairman, members of the committee, I'm Amy Epson, JLBC staff. You should all have in front of you a blue presentation, and I'll be making a presentation today on the draft legislation of the executive Medicaid proposal. The presentation is broken up into two sections. During the first portion, I will provide an overview of the proposal, then I will discuss the costs of implementation. And you can follow along with me beginning on page 3.
You get all the yeses on it. Yes, just
The executive proposal would expand Medicaid coverage for adults up to 133% of FPL. Currently, the statutory eligibility is 100% of FPL. And just as a reminder, FPL stands for federal poverty level. Right now, 100% of FPL is about $24,000 for a family of 4, and for 133% of federal poverty level is about $31,000. While the federal law requires that the state expand eligibility for children up to 133% of FPL, the adult expansion is optional. The proposal would also be discontinued if the federal match rate falls below 80%, and I'll go into more detail on that a little bit later on. The executive proposal would also update the definition of the way in which income is calculated to coincide with federal law. Additionally, it would effectively restore the coverage of the Childless Adult Program. As you may recall, the Childless Adult Program has had a freeze since July of 2011. By that, I mean anyone who was on the program at that time can continue to remain on the program as long as they remain eligible, but no new applicants are being accepted. This freeze was achieved through the budget process, and population remains eligible under current law. If you turn to page 4, you'll see a chart that displays Medicaid eligibility. As you can see from the legend, the traditional population is the solid white color. The Proposition 204 population is represented by the diagonal stripes, and the Kids Care program is represented by the dotted section. There's several things I want to point out to you about this chart. In addition to the Childless Adult freeze, which I mentioned earlier, there's also a freeze on the Kids Care program. You'll also notice on the chart that for children ages 6 to 18, the segment from 100% to 133% of FPL is shaded with a horizontal line. And that's because, as I mentioned earlier, beginning in 2014, the federal government requires that the state expands eligibility up to 133%. Since children under age 6 are already eligible for Medicaid coverage, this only impacts children from age 6 to 18. This chart also shows which populations the executive is proposing to expand. In order to pay for the expansion, the executive is proposing a hospital provider assessment. And before I go into the details of the plan, I want to just provide an overview of Medicaid provider assessments. And I'm now on page 5 of your presentation. The federal government allows provider assessments to be used as state matching funds for Medicaid programs, and they can be applied to different types of health care services. In this case, the governor is recommending that it be applied to hospitals. The federal government also allows different assessment bases, such as it can be applied to items or services, number of beds, or the amount of revenue. And exclusions can be applied, such as to inpatient or outpatient services, to certain revenue streams, such as Medicare, or to various types of hospitals. Continuing on page 6. Ultimately, the methodology, rate, and amount must be approved by the federal government. And the federal law includes several different limits on hospital assessments. First, it's limited to no more than 6% of revenues. It's actually not quite a hard cap, but it's one of the tests that they use to see whether or not it can be allowed. In addition, a state cannot receive more than 25% of the state's share of the Medicaid expenditures through provider assessments. And finally, providers cannot be held harmless. And what I mean by that is a hospital cannot be guaranteed that whatever they pay in for the assessment, they will receive back. Page 7 outlines the specifics of the executive's plan. The executive proposal would require that Access establish and administer a hospital assessment which could fund access coverage for adults from 100% to 133% of FPL. The assessment could also fund the general fund cost of the Proposition 204 population. While it's not stated in the bill, I do know that the executive budget estimated that in the executive budget, the estimated amount for the assessment only funded the access portion of these costs and not the behavioral health portion in DHS. And that was a small, and the DHS proportion is just a small amount of the overall Medicaid budget. The executive proposal also provides access with flexibility in determining the methodology and its rate. As I discussed earlier, access could assess a fee on inpatient or outpatient revenues, on number of hospital beds, number of discharges, or a number of other items. Access would also have the authority to determine exemptions based on hospital size, specialty services, and geographic location. Access is currently working with a consultant on the specifics of the proposal. The proposal also includes what is referred to as a circuit breaker. If at any point in time the federal match rate for the adult expansion or for the childless adult population falls below 80%, both the assessment and the expansion would be discontinued. Just to give you a better idea of how the federal match rate works, right now most services receive a 2-to-1 federal match, but the federal healthcare legislation introduced a few new match rates. For adults from 100% to 133% of FPL, we'll be receiving a 100% match rate for the first 3 years, and then that slowly declines to 90%. Additionally, if the state decides to expand Medicaid coverage up to 133% of FPL, we'll be eligible for an enhanced match for the childless adult population that's between 0 and 100% of FPL, and that match rate's about 85%, and it increases to 90%. Finally, one other component of the proposal is that it would prohibit local assessments. Right now, there's one city that has an assessment, that's the city of Phoenix, and I believe that assessment expires at the end of the year. Moving on to page 8, while Access does have a lot of flexibility with the assessment, the executive hasn't incorporated several different ways that the agency would receive feedback on the proposal. Access would be required to establish a hospital work group that would consist of urban, rural, and critical access hospitals. It would also be required to undergo a JLBC review before implementation, and then annually thereafter if the methodology is modified. The proposal also includes an exemption from rulemaking requirement, but it does allow a 30-day comment period. Now that I've provided an overview of that, I'd like to discuss the costs of the proposal, and those begin on page 10 of your presentation. Although we discussed this at the Appropriations hearing last month, I do want to refresh your memory on the mandatory costs associated with the federal health care legislation, because there's been some confusion on what is mandatory and what's optional. As I mentioned earlier, coverage for children will be expanded to 133% of FPL beginning in 2014. And then we're also expecting a number of individuals to apply for the program who were currently eligible but not enrolled. Our baseline estimates that about half of those who are currently eligible but not enrolled will ultimately enroll, or about 135,000. And as we've said before, these numbers are difficult to forecast, and I'd caveat this by saying that back in 2000, we did underestimate expansion by 100%. Additionally, the federal government requires 2 rate adjustments. The first is a temporary rate increase for primary care providers, and the second is a nationwide fee that's imposed on health insurance, and we estimate that'll be around 1.3% of Medicaid costs. Page 11 shows the overall cost of these mandatory requirements. The JLBC estimate that mandatory requirements will cost about $74 million in FY14, and then there'll be a little bit over $200 million in each of FY15 and FY16. Ultimately, by the end of 2015, we expect that an additional 168,000 new people will enroll. Page 12 provides an overview of the costs for the optional expansion. As I said earlier, the executive wants to participate in the optional expansion, and we estimate that that will cost about $6 million in the fiscal year 14, and about $100 million in each of FY15 and FY16. And let me explain the components of those costs. First, the expansion would end up eliminating the childless adult freeze, and these individuals, which are currently matched at, and individuals who apply for the program would be matched at around the 85% match rate. Second, the childless adults who are still on the program, so those that were frozen, will receive that increased match from 66 to 85%. And then third, coverage for all adults would expand from 100% of FPL to 133% of FPL. The cost of this would be borne by the federal government for the first 3 years, and then it would eventually decline to 90%. By FY 2016, we estimate that this will draw down an additional about $1.7 billion in federal funds. Page 13, you'll see the estimated cost for the executive proposal. In her budget, the executive estimated that the provider assessment would be approximately the general fund equivalent of the cost of the Proposition 204 program, plus the cost of the newly eligible adults. So this would potentially cover more than just the cost of the expansion. The executive estimates that the optional cost would be $27 million in FY14, and then $154 million in FY15. The provider assessment would then generate $82 million in FY14 and about $250 million in FY15. And so overall, the net savings would be about $50 million in FY14 and $100 million in FY15. And on the last page, the chairman asked a couple of different questions which he wanted me to address in this presentation. The first of which is, what is the level of the provider assessment if the match rate falls to 80%? Right now, we're estimating that in fiscal year 15, provider assessment would be around $250 million. If the match rate did fall to 80%, it'd be about $365 million. Also, the chairman was wondering what would happen if the government eliminates the provider assessment. And if that were to happen, then the cost would shift to the general fund, unless a new source is identified. So, for example, if the provider assessment was budgeted to pay for $256 million of the cost, then that $256 million would be shifted to the general fund. And before I end my presentation, I do want to say that there are a number of other policy issues that could be considered regarding this issue. While they're certainly relevant to the discussion, my presentation has simply focused on an overview of the proposal and the costs that are involved. And this concludes my presentation. I'd be happy to answer any questions.
Thank you, Amy. I have a few questions. Before we get to questions, I just want to mention for those that are observing that the committees in the House and the Senate are going at the same time, and so members of the House Appropriations Committee at times will have to step out to go testify on their bills in the Senate, as Chairman Kavanaugh has had to do. But with that, would like to open it up for questions, and I'd like to start. I do have a question for Amy regarding the provider assessment. I wanted to get your input on whether this would trigger a Prop 108 clause in the bill, and, well, first of all, if you could just speak to that, whether the proposal as drafted would trigger a Prop 108 clause.
Mr. Chairman, just to give you some background on the issue, in 1992, Arizona voters passed Proposition 108, which requires a 2/3 vote from each chamber to impose a new tax or fee, or to increase an existing tax or fee. And there's an exemption in that for fees and assessments that are authorized by statute, but are not prescribed by formula, amount, or limit, and are set by state officer or agency. For the record, I'm not a lawyer, and I don't feel comfortable answering that question. I think that would be better answered by your lawyers.
Thank you, Amy. Maybe you have some additional information on the history of fees that fall under that exemption. I'm wondering if we have any precedent of a fee that's raising nearly $300 million that fell under that exemption in the past, or if this would be the first time that we've established a fee and allowed an agency to set that fee under that exemption from Prop 108 that generated $300 million.
Absolutely. Mr. Chairman, in the past, the legislature has given uncapped fee authority to various agencies. And with those, and when it has, the lawyers have said that that was legal. It has never been quite as high as this amount. I don't know if there's a differentiation between the two, and once again, I think that would be better addressed by lawyers.
Mr. Chair, to that point, though, really quickly, if I could, Mr. Chair and Amy, in the languages passed by the voters, is there any cap in terms of the Prop 108 issue? Is there any cap in the language passed by the voters about the amount a fee could generate?
Mr. Chairman, Representative Campbell, no, there's not a dollar amount.
Thank you.
Thank you. And Amy, do we have any examples of what has been the typical amount of fees that are being raised by an agency that's authorized to set that fee? And the reason I ask this in context of Representative Campbell's question is, are we creating an exemption so large to Prop 108 through this practice, this unprecedented level of raising fees, raising a tax and calling it a fee and giving an agency the authority to levy that or establish the limit of that fee? Is this an unprecedented expansion of that exemption to new levels? And so I'm wondering if you could describe, if you have any context on what is the level of revenues that have been raised under this exemption in the past. What is the maximum? If you have it, if you don't, we can get that information.
Mr. Chairman, that's an excellent question. I don't have that information available with me right now, but we can get that to you.
Excellent. Well, thank you so much for your presentation. It was very informative. Members of the committee, any additional questions for Ms. Upston? Representative Quasman.
Yes, thank you. Can you please explain to the committee how they go about with the provider tax? How is that assessed? How does that operate? Where are the numbers put together? Is there a formula for that, for the provider tax itself?
Ms. Upston.
Mr. Chairman, Representative Quasman, there are a number of different states that have a provider assessment. I believe there's about 39 who specifically have a hospital assessment, and they all look very different. For example, it could be an assessment could be charged on the amount of net revenues. There could be a bed tax, for example. You could charge $5,000 or $2,000 or $10,000 for every hospital bed. It could be levied on the number of discharges or anything else. The way the draft bill was written, and it gives flexibility to Access to design that. Now, from my understanding, Access has recently hired some consultants, and they're working with them to run some numbers and see what would happen. Like I explained earlier, there's quite a bit of flexibility. You can exempt certain hospitals, like if, for example, they felt it was in the best interest to exempt hospitals in a certain location or a certain type of specialty hospital or public hospitals or something like that. They're allowed to do that. But then there's certain limits when there's certain limitations that when you exclude certain hospitals that have a high share of Medicaid recipients, you also have to exclude other hospitals that have a low level of Medicaid recipients. So it's a complicated procedure. Ultimately, the federal government has to approve anything that a state designs. And so right now, I can't say exactly what that would look like. I don't think anyone knows at the moment. I know they've been, one of the reasons that they hired the consultant is because they want to also work with the hospitals and get some input on that, because some of the hospitals have expressed various concerns about that. And so they're looking at what can be done with those concerns.
So, Mr. Chair.
Representative Quasman.
So I guess the follow-up is that if there is some sort of standardization, if there is a formula when it comes to it, would that not then be an inconsistency with the Prop 108 exemption?
Mr. Chairman, Representative Quasman, I wouldn't call that a formula because in at least the draft legislation I've seen, there's no specific formula. It allows them to have flexibility.
Representative Quasman.
Furthermore, I just wanted to ask, you said in 2000 the expansion underestimated growth by 100%. Can you please put those into real numbers, as opposed to a percentage? The actual underestimation.
Ms. Upston.
Mr. Chairman, Representative Plasman, I want to say it was around 125,000 that they expected would enroll, and ultimately it was about 250,000 that enrolled.
Mr. Chairman, to that point,
Representative Plasman.
how do, in terms of calculating these estimates, where do you think that whether it's the executive or JLBC has improved in their methodology in terms of any type of estimation of where any type of future expansion?
Mr. Chairman, Representative Plasman, I'm not sure how they were calculated back in 2000. I wasn't around for that, but I know one of the things that happened back then is very few states were actually covering childless adults at that time. I believe right now there's only 5 or 6 states that cover them, and so one of the challenges was they weren't sure how many there were and whether or not they would enroll. We're estimating that about 50% of those who are eligible, meaning those that are uninsured and then are within those income guidelines, would ultimately enroll. And we've been very straightforward in saying that our estimates could be off. We don't really know because nothing like this has been done before, and so we may, they could be a little bit off. We could underestimate them.
Okay, that's good, Mr. Chairman.
Representative Plasman.
And with the expansion existing, just to do my fun supply and demand curves over here, if you're going to subsidize demand and you're shifting the demand curve to the right, what do we see? Do you have any estimates in cost increases based on this expansion? The cost increases of healthcare based on an increase in demand?
Mr. Chairman, Representative Plasman, I think this is a really complex question because I don't know that these people would necessarily increase costs. It's possible that it's certainly possible that they could, but if they're not already on Medicaid, part of the reason might be that they're not utilizing services very much, and so that's why they're not on there. But I mean, as far as the woodwork effect, which I think you're referring to, those who are eligible but not enrolled, regardless of whether or not the state enacts the expansion, those individuals are going to end up coming on to Medicaid regardless.
Any further questions for Ms. Upston? Seeing none, thank you, Ms. Upston, for your compelling presentation. Next we have